Hi, I'm Andrea Russo. I'm the immediate past president of the Heart Rhythm Society. So thank you for joining us at this session today to discuss a really interesting survey that was initiated by the Heart Rhythm Society Communications Committee, which Rakesh chairs. First of all, I'd like to thank the Communications Committee members. I'd like to thank Rakesh and that committee for all their hard work with putting this survey together and sharing it with everyone and joining this session today. Great news that it's been accepted for publication, so we're very thrilled to hear that. So you'll be seeing more details even after the presentation. I'd also like to thank our partners, our leaders of other societies around the world for their participation in this survey, and for the EP community in particular who've completed the survey questions so that we have this information possible. So I'm going to start out by introducing Dr. Rakesh Gopinathannair, who is the chair of the Communications Committee of the Heart Rhythm Society. Rakesh.
Thank you, Andrea. Thank you for the opportunity to present this. So this, what I'm going to share the results of this global survey that was developed from the FHRS Communications Committee and disseminated by FHRS. So this is particularly focused on COVID-19 and cardiac arrhythmias and a global perspective on the arrhythmia characteristics and management. Essentially, as a background, arrhythmias appear to be common in hospitalized COVID-19 patients. However, the manifestations, what type of arrhythmias, as well as the treatment strategies used in these patients have not been well described. The objective of this survey was to better understand the cardiac arrhythmic manifestations as well as treatment strategies employed in hospitalized COVID-19 patients through a worldwide cross-sectional survey. So coming to the methods, this was a survey that was initiated by the Heart Rhythm Society and developed by the FHRS Communications Committee with input from the FHRS COVID-19 Rapid Response Task Force. The survey had 25 questions and was active from March 27 to April 13, 2020. And as Andrea mentioned, the audience for the survey was electrophysiology professionals worldwide. These include physicians, allied professionals, research scientists, and all other arrhythmia professionals. And this was disseminated through dedicated FHRS member email, as well as through emails sent to Arrhythmia Society leadership across the world, as well as social media portals. And so there were three different ways we send this survey out. Standard statistics were used, and the results. This particular table shows the demographic characteristics, and it's also in the first column for the all the patients. We had 1197 respondents within that time frame. And 50%, almost 51%, 50% were from outside the US. And if you look at the majority of them were practicing electrophysiologists, and the type of practice differed, was most commonly hospital-based practice followed by academic practice. And when you look at USA alone, 44 arrhythmia professionals from 44 states participated or completed the survey. Whereas from a global perspective, we had participants from 76 countries and involving 6 continents. So truly global response. When you get into the details, out of the 1197 respondents, 76%, that is 905, reported having COVID-19 positive patients in their hospital. The total number of hospitalized COVID patients for all the respondents was 41,422, and which comes to a mean of 61.4 patients per respondent, and the median was 16. When you look at the characteristics of, so now the next 2-3 slides, I'm going to go through the arrhythmia types, which is going to be separated out by tachyarrhythmias and bradyarrhythmias. Then we'll also look at anticoagulation therapies, antiarrhythmic therapies. And lastly, we'll discuss about the sort of hot button item, which is the use of hydroxychloroquine with or without azithromycin in these patients. So again, I want to preface this by saying that these are all responses from the survey respondents. And I just wanted to point out that in the beginning. So in terms of tachyarrhythmic manifestations, the most common tachyarrhythmia reported was atrial fibrillation. And among the 683 respondents who replied to this particular question, almost 20% reported seeing atrial fibrillation in these patients. There were a wide variety of supraventricular arrhythmias, including atrial flutter, sustained atrial tachycardia, paroxysmal SVT. And when you come to ventricular arrhythmias, again, frequent monomorphic and or multimorphic PVCs were seen in small percentage of patients, as you can see here. And non-sustained VT was seen reported by about 6.3%. I want to sort of emphasize the fact that, there's been a lot of discussion about ventricular sustained or life-threatening ventricular arrhythmias in this particular population, especially given the concern over myocarditis and similar inflammatory processes. So 3.5%, about 24 respondents reported seeing polymorphic VT or torsade de pointe, and ventricular VT-VFRS was reported by 4.8, almost 5% of respondents, and PEA or pulseless electrical activity was reported by close to 6%. And so these are, important because this is an aspect that is being recognized more and more and should not be, should be considered, the possibility should be considered in every hospitalized COVID patient. So, so to summarize, I mean, the pie chart on the right side shows these the percentages of these arrhythmias in these patients in a better fashion. So again, atrial fibrillation was the most common tachyarrhythmia, and life-threatening arrhythmias were seen in small proportion, but not inconsequential at all. Moving on to bradyarrhythmias, again, 663 respondents, responded to this particular question. Two bradyarrhythmic manifestations sort of stood out and were reported by approximately 8%, about 51 respondents. And these were severe sinus bradycardia and complete heart block. And there is a more of an understanding about or more and more reports have come out regarding heart block and AV conduction abnormalities. If you look at first degree, second degree AV block, small percentages were reported. And similarly for His-Purkinje system abnormalities, including bundle branch block and IVCDs. So again, the pie chart shows the spread of the bradyarrhythmic manifestation. Again, a variety of bradyarrhythmias were noted. When you, in terms of anticoagulation, so the setting here is that COVID-19 has been reported to be thrombogenic, and the exact mechanisms remain unclear. In our survey, 140 of 645 respondents, approximately 22% responded that they used empiric anticoagulation therapy in COVID, and all of their COVID-19 patients who otherwise did not have an indication for anticoagulation. And out of the 140, 63%, the majority used intravenous heparin or subcutaneous low molecular weight heparin, whereas 31% responded using novel oral anticoagulant, and minority used warfarin in this case. When you look at antiarrhythmic therapy, amiodarone, again, the question that we asked was only regarding ventricular arrhythmia management. We didn't ask about atrial arrhythmia. For COVID-19 patients with ventricular arrhythmias, amiodarone was the commonest antiarrhythmic drug used, and it was used it was reported by approximately 34% of the respondents. And about 160 out of 628 respondents reported seeing LV dysfunction in COVID patients, which is also a significant number in these. Again, we do not know based on the survey whether this was a pre-existing condition versus the de novo thing, that those things that needs to be further delineated. Moving on to the next one. So about, this has become center stage in the COVID-19 pandemic, is the use of hydroxychloroquine, and it's multiple publications have come out, and we still don't have a clear answer on, a convincing answer on efficacy, but safety concerns have been reported. So in our survey, we asked two separate questions. What percentage of them are you using hydroxychloroquine alone? And how many of you are using hydroxychloroquine plus azithromycin? As you can see here, 34% of the respondents reported using hydroxychloroquine or chloroquine, either or, whereas another 31% for the next person reported using a combination of hydroxychloroquine and azithromycin. We were very interested in finding out whether there was differences between this use in US practitioners versus the global practitioners. So when you look at the data, I'm just going to focus on the hydroxychloroquine plus azithromycin aspect. More people outside the US reported not using the combination that much. Overall, if you look at, and in the US, 55% responded saying that they are using in some patients, but not in all. And about 12% responded saying that they use in all the patients. Whereas the numbers globally was a little bit on the lesser side. So more people in the US tended to use both hydroxychloroquine as well as a combination. And so again, it's statistically significant. So there's a variability in the patterns of use between the United States and the rest of the world, as per the respondents. What about adverse effects? In terms of, we have gone through, there are several QTC monitoring algorithms, and flow charts have been reported in various publications. So we asked the respondents whether they used a QTC monitoring protocol when they used hydroxychloroquine in these patients. So about 50% of the 508 respondents reported that they used a QTC monitoring protocol. And 20% reported magnesium supplementation in all patients on hydroxychloroquine. Interestingly, QTC prolongation greater than 500 milliseconds or 550 in patients with wide QRS was reported by about 17%. 80 out of 477 patients, respondents reported seeing QTC prolongation above the normal limits. And and in another question, we asked them about Torsades as well as did you have to discontinue the drug based on QTC prolongation? 60 of 489, about 12% reported that they had to discontinue hydroxychloroquine. And 20 respondents, about 4%, reported cases of Torsades de Pointes in patients with hydroxychloroquine and azithromycin. And again, the last two bullet points here specifically refer to people who are on combination therapy. When using hydroxychloroquine plus azithromycin, we saw 12.3% reported needing to discontinue, and 4.1% reported seeing Torsades. So again, these were not also important things to keep in mind. To summarize, what are the major discussion points here? Our goal was to sort of provide an overview of what EP professionals across the globe are doing to treat arrhythmias in these patients, as well as to understand what arrhythmias are being reported. And the need for this was because initial reports from China in Wuhan reported arrhythmias in COVID-19 patients who were hospitalized. However, there was no clear details given as to what type of arrhythmias or how they even classified arrhythmias. So we felt that it's important to get a better understanding of that. So what we noted based on the results of the study was that in hospitalized COVID-19 patients, a wide variety of arrhythmic manifestations were reported, and including life-threatening ventricular arrhythmias, which are sustained monomorphic VT, polymorphic VT, Torsades, or VT FHRS, and also pulseless electrical activity. All these are have been seen in hospitalized COVID-19 patients. Atrial fibrillation was the most common cardiac arrhythmia, whereas among bradyarrhythmias, severe sinus bradycardia and complete heart block were the most common bradyarrhythmias reported. 22% of the respondents reported using therapeutic anticoagulation in patients who otherwise did not have an indication. There was wide variability in the use of hydroxychloroquine with or without azithromycin, and the concomitant use of azithromycin was more common in the United States. And discontinuation of hydroxychloroquine or chloroquine along with azithromycin due to marked QT prolongation was reported by 12.3% of the respondents to that question, whereas 4.1% reported seeing Torsades points. We did not have data to say whether it was sustained Torsades versus self-limiting, so it cannot be extrapolated to say that these are all life-threatening. So it may not be, but they reported seeing Torsades type episodes. So one has to really acknowledge the significant limitations the survey-based methodology creates. Although there is interesting information here, these are all based on what the respondents experience. So their opinion may not represent the entire EP community. There is always a challenge with survey regarding recall bias, and you tend to remember the sicker patients. Being the audience being EP professional, it's likely that there may be a selection bias for sicker COVID-19 patients at increased arrhythmic risk, and may not be, that's another drawback. Respondents working in the same institution, we didn't send it to institutions, we send it to individuals. So there may be more than one respondent from the same institution, maybe referencing to a same patient. The information on various arrhythmias presented may not represent the accurate incidence and should not be construed as such. A reported brady or tachyarrhythmia could have been de novo, or it could have been pre-existing. We did not specify that in our questionnaire, so that's also another limitation. And one should not make any association between underlying conditions and severity of illness and arrhythmic manifestations. We didn't have clear information as to how many of them were ICU patients versus how many of them were at the hospital. So we could not correlate these arrhythmic manifestations to their underlying sickness levels. So in conclusion, in this global survey of more than 1,100 EP professionals, a wide variety of arrhythmic manifestations were noted, ranging from the benign to the life-threatening in hospitalized COVID-19 patients. Observed adverse events related to the use of hydroxychloroquine when combined with azithromycin included prolonged QT interval requiring drug discontinuation as well as Torsades points. Hence, caution should be exercised and close monitoring should be advised when initiating these patients in the hospital. This hopefully will set stage, could be hypothesis generating and could set the stage for large prospective studies to better define arrhythmic manifestations, as well as the safety and efficacy of various treatment strategies in COVID-19 patients. With that, I conclude my presentation. I would, as Andrea mentioned it before, the authors would like to convey their sincere appreciation to all the arrhythmia professionals who shared their experience by completing the survey. We thank the FHRS for supporting this endeavor, and we also want to give a big applause to the members and staff of the FHRS Communications Committee and the COVID-19 Rapid Response Task Force, without whom this would not have been possible. And we also thank several of the arrhythmia societies and cardiology societies across the country as listed here for their support to this project. Thank you. I'll return it back to you, Andrea.
Thank you, Rakesh. That was great. That was really a nice result and really a great contribution and a great number of people who responded. So congratulations on the survey results. I'd like to now introduce our remaining panel members is Dr. Faisal Merchant, who's also a member of the Communications Committee, has joined us, and Dr. DJ Lakkireddy, who's the chair of our Global Relations Committee. So thank you for joining us. And so we'll spend the rest of the time, asking some questions and getting a panel discussion going here. Let me start out with DJ. One of the fears we've all had, we heard Rakesh gave us some information on ventricular arrhythmias. So we've had this fear that the disease process itself can promote ventricular arrhythmias, or perhaps the treatment of the disease may promote arrhythmias. So can you tell us, I know you've had some experience at your center with this. Can you tell us a little bit about what you've seen and what your thoughts are?
Andrea, thank you for the opportunity again. I think the data looks fantastic. And in terms of ventricular arrhythmias, I think the obvious concern is if these ventricular arrhythmias are primarily related to the coronavirus infection by itself, or is it secondary to all the multi-system effects that the virus could do in terms of your hypoxic respiratory failure, renal failure, and if there is GI involvement, can there be significant levels of electrolyte abnormalities? And then the entire spectrum of ventricular tachyarrhythmias that are exacerbated by anxiety, sympathetic surge in patients who have a pre-existing cardiomyopathic substrate. I mean, most of these patients obviously might have had cardiac defibrillators in place, and do VTs get exacerbated in this? So the answer to that is yes. And it's interesting how there is a variable presentation of ventricular arrhythmia. So we studied this exact aspect of it. It's a multi-center collaborative cohort of patients that we looked at. So when you look at COVID patients alone, COVID positive patients alone, these COVID patients can have arrhythmias related to obvious involvement of the myocardium causing myocarditis. Luckily, that portion of people who have COVID myocarditis and associated ventricular arrhythmias are relatively smaller. And then there is a large cohort of patients that really don't have any myocardial involvement. They don't have any ventricular arrhythmias. But then these are the people that have had vascular involvement with venous thromboembolisms that end up developing pulseless electrical activity and asystole. And these are the same group of people that actually also had delayed presentation of sudden cardiac death when they got discharged from the hospitals. And some of the postmortem analysis of these patients ended up showing pulmonary emboli. So the interesting aspect of it is for COVID patients, positive patients, a vast majority of these patients actually have PVCs. About 50 to 55% of the patients actually present with PVCs. Mostly monomorphic, sometimes polymorphic. And about 11 to 12% of the patients actually present with either sustained or non-sustained ventricular tachyarrhythmias. And the overall incidence of torsades is actually pretty rare. As Rakesh's study shows, atrial fibrillation, again, is a very common presentation because of the lung involvement, elderly patients with a significant number of risk factors for atrial fibrillation, new onset atrial fibrillation or exacerbation of an existing atrial fibrillation could be very common. What we found even more exciting and interesting is there was a surge of ventricular tachyarrhythmias in patients who have underlying known cardiomyopathic substrate with ICDs. So we have seen a lot more VF storms presenting with recurrent ICD shocks that presented to the hospitals during the same time. Most of them were PUIs. And so when we did the COVID testing on them, a significant number of them came back to be negative, clearly showing that it was not the acute myocardial involvement from the coronavirus that caused these VT exacerbations. And perhaps this is probably related to increased sympathetic surge related to general sense of anxiety, almost like a post-traumatic stress disorder type of a scenario where patients had ICD shocks that underwent antiarrhythmic drug therapy. And in some cases, we even took them to the lab to ablate their ventricular tachycardia since the VT was not amenable to arrhythmias. So I think there is a significant variation in the presentation of ventricular arrhythmias, depending on their COVID status, depending on whether they have underlying cardiomyopathic substrate or not. So I think these are the little nuances I think that are very important to understand when we take care of patients coming in with ventricular arrhythmias during this COVID pandemic.
That's great. No, that's interesting. So I guess we'll also have to see what happens in the long term. And this is all acute so far, and you know what the disease process gives us for the long term. So, you know, it's interesting. There's a lot more in the survey. Before we get into more details on the survey results and questions on that, you know, the one thing that struck me is, as we're talking here, is that the importance of dissemination of information. So rapidly communicating information, so whether it be ventricular arrhythmias or other issues related to COVID patients, that has really been you know, a key to what's been going on. So as you know, the FHRS has initiated a COVID rapid response task force. So, and that one of the purposes is to disseminate information rapidly and to, you know, curate information. The other thing we have is this member community, so that HRS members can communicate in the COVID-19 community. And then we also have a website, you know, that allows us to display some of the information. So, you know, certainly it gave us the opportunity, the scientific community, the opportunity to share information quickly. So let me ask, you know, since you're at the communications committee and Faisal, in terms of communication, you know, what do you think we learned, you know, lessons learned from the COVID-19 pandemic? You know, what were the challenges? What did we get right? What might we do differently? And hopefully we won't have another, you know, surge, but, or you know, something in the future. What are your thoughts about the process?
Yeah, thanks, Andrea. I think you make a great point about the need to gather information very quickly. And I think undoubtedly COVID has challenged the medical field broadly, certainly society around the world, in a way that I can't really think of anything analogous, certainly in the last couple of decades. And, you know, there's been a real need to gather information very quickly. Certainly in EP, we as a field have been challenged, as I suspect many other medical disciplines have. And this survey, I think, shows the ability, using the platforms and the tools that the Heart Rhythm Society put into place, email, online communities, engaging with our partner sister societies around the world, to be able to collect information very rapidly from a large number of electrophysiology professionals around the world in a pretty short amount of time. And I think it was really helpful to be able to get some perspective on what people are seeing in other countries, what the spectrum of arrhythmic manifestations is that they were seeing, and what forms of treatment they were using. And I think, you know, Rakesh did a nice job of highlighting some of the heterogeneity between the US and other countries in terms of use of hydroxychloroquine and other agents. I think it's helpful to see some of those patterns. And I think that this survey really highlights our ability to collect information in a short amount of time. Obviously, I think, you know, thinking about, heaven forbid, were something like this to happen again, where we needed to collect a lot of information in a very short amount of time. And I think we've learned that we have the tools in place in order to do that. I think that potentially moving forward, if we were to do a survey like this again, it might be helpful to learn a little bit more about the specific institutions where people were. As Rakesh mentioned, one of the things the survey doesn't capture is whether we had medical professionals at the same institution responding to the survey, in which case they may be reporting the same arrhythmic events in different patients that those EP teams have seen. And so we might choose to try to learn a little bit more about specific institutions. We might ask a little bit more granular detail about the numbers of patients, as opposed to just doing a per respondent, but asking respondents specifically how many patients they've seen. So I think we could potentially learn a little bit more in detail. So some of the design elements of the survey, I think, potentially will be instructive for the future. But I think really, as a take-home message, this survey shows the power of organizations like HRS and our sister organizations to be able to collect information from across the EP community in a very short amount of time, in really a cheap and highly effective platform. And I think that's really been probably the take-home message for me.
Really, really impressive, I think, to get the community together as you have done, and to reach so many different areas, and to really see what different thoughts are in different areas, and to see how these patients, and to learn from each other as the waves of patients come through different regions of the country or different countries. Now, thank you. Rakesh, I know DJ talked about ventricular arrhythmias. You know, it's interesting that the patients also can have, you know, bradyarrhythmias and heart block. You know, kind of think of that too much in acute myocarditis. We usually think of other, you know, other things like, you know, more rapid rhythms. But I thought that was interesting. I don't know if you have any other further comments on that, or other thoughts on what other unanswered questions do we have, and what other kind of next steps would you recommend to kind of either look at these patients, quantify incidence of arrhythmias, or what are your thoughts as to what to do next?
Great. Thank you for that question, Andrea. So just to add to what DJ mentioned, I think, you know, bradyarrhythmias, especially severe sinus bradycardia or complete, I mean, was described by 8% of our respondents, and also complete heart block by around about the same. So the question then becomes, I mean, we obviously don't know the demographics of these people who develop complete heart block, whether it's a degenerative disease that gets worse with inflammation, or with just because pneumonia causing hypoxemia and causing, you know, they may be intubated, and that may be part of the reason. I think, you know, so just to give you one aspect about life-threatening bradyarrhythmias, especially asystole. So there was a study from China that looked at 136 patients who were resuscitated during, you know, while admitted with COVID, and they noted that about 87% of them, you know, they ended up doing. They found that the vast majority of them had asystole as the rhythm, and out of the 136, vast majority of them had respiratory disease leading to these arrhythmia, asystole in that case. About PEA, or pulse electrical activity, was noted in 4.4%, whereas a shockable rhythm was only seen in about 5.7%. So the numbers that we have in our survey is actually fairly consistent, you know, even though these are respondents, with what the, you know, single center data that shows. And they reported very poor outcomes out of the people who underwent, you know, CPR and the whole ACLS protocol. Were only 13.2% recovered circulation, and only one patient out of this 136 ended up having neurological recovery. So it was very poor outcome. So that is some, you know, but, you know, from our standpoint as EPs, you know, I think my important thing to take home is we want to understand what happens to these patients long term. And I think, you know, unusual manifestations of this virus has been reported. And then we want to know, is it a transient phenomenon? Is the heart blocks developing, or is it a permanent thing? Do these people have residual myocardial inflammation? Do they need MRIs or PET scans or something? And then are they at risk for ventricular, you know, so, or bradyarrhythmias down the road? I think they need close follow-up, some kind of monitoring, in my opinion. And then I think there's a lot more to learn. I think, you know, it's sort of become, it's been puzzling, some of the manifestations, and I think we'll learn as we follow up these patients who are recovered, and are they is their myocardium fully recovered? Are they still having inflammation? I think those are some of the things. Is their lung function back to normal? Or if not, is there any, you know, fibrosis in the lungs? So can it lead to some other things? So a lot of these unanswered questions, and I think we are basically scratching the surface here. We don't know the full extent of these manifestations. I think we need to study more.
Yeah, no, great. No, thank you. Yeah, that's, I agree. So, you know, the other thing I think of too is some of these patients in some hospitals, if they have a large volume of patients, some may not even be monitored. So you're only seeing the sickest patients maybe being monitoring. So what is, you know, what's the overall, you know, denominator? What happens, you know, subsequently? So I think we still have, as you alluded to, have a lot more to learn in this cohort. You know, I just thought maybe I ask each of you, what do you think is the most important message that we get from this experience of COVID, doing the survey? what do you think is the most important message to take home?
So I think this will, I mean, the important take home message as we saw this is it really gave us a pretty good panoramic view of what could be happening in different groups of populations. I think as we are aware, I mean, the disease manifestations of, I mean, even something as pandemic-like as Corona could be, can have different manifestation in different groups of people. And the response to the so-called antiviral drugs or hydroxychloroquine could be very different based on the genetic makeup of individual groups of people based on the geopolitical distribution. I think what we saw that heterogeneity in the adverse effects that are reported with the hydroxychloroquine use. I mean, papers that came from different regions of the world had different outcomes. So I really think this really provided an unprecedented opportunity in the worst case situations for us as a medical community, as physicians, to really understand the global manifestations of a pandemic. And I really appreciate the leadership that HRS took in this, in really becoming a global organization, in bringing people and scientific endeavors together onto the singular platform so that we can disseminate this information as rapidly as we are able to today.
Yeah, so I certainly, I thank all of you for allowing us to do that. And one of the dissemination is, as many of you have been involved in too, is even putting out publications in a very rapid format and multi-societal documents. We did several, as part of the COVID task force and as part of HRS initiatives. So, Faisal, what do you think? What are some of the take-home most important things for you from this whole experience?
Yeah, it's interesting. You mentioned for instance, the fact that we may not be seeing all of the cases. There's likely some underreporting because of availability of telemetry. I think the same thing that's really been a big issue, obviously, is the availability of tests and even drawing, any kind of sense of whether particular arrhythmic manifestations are due to COVID or not, obviously depends on the availability to test, and not only the availability, but how good are the tests? We know the tests aren't perfect, far from it. And so BJ earlier mentioned that, a lot of people have ventricular arrhythmias and they test negative. Are those false negative tests, or are they truly ventricular arrhythmias that are unrelated to viral infection? And I think it really highlights a lot of the challenges of trying to study a brand new disease, right? I mean, this is something that a few months ago, none of us had heard of. There were no billing codes or ICD-10. We didn't have diagnostic tests. And so it's very much on the ground learning from each other. But it's hard because, without knowing what availability there is for testing, what availability there is for telemetry, post-discharge follow-up, those kinds of things, it makes it difficult to even put the results of a survey like this into geographic context, right? I mean, we had respondents from, I think, 6 continents or something like that. And the results from sub-Saharan Africa really need to be taken in the context of the medical system there and the availability of testing and resources and things like that. So I think it really does, there's great power in having a global organization, global reach, and being able to collect data. But it also, it sets up new challenges in terms of being able to contextualize that data appropriately and really understand it in the context of the respondents and the details of how they're practicing, where they're practicing, or what resources are available. So, with all opportunities come more challenges. And I think certainly COVID has demonstrated that in spades.
Yeah, no, great points. And certainly, the variation in the facilities and in the treatments, and especially when we don't have a lot of, good randomized, trials right now to say what works and doesn't. So just what people pick in different regions may be what's more available. Great, terrific points. And Rakesh, so your effort in leading this has been truly incredible. I want you to say some words on what you think, what your thoughts are on that. What are our most important messages to give the EP community at this point?
Thank you, Andrea. I appreciate it. I mean, it was truly a total teamwork. And so in my point, I mean, I want to echo what DJ mentioned initially about, sort of setting a baseline, sort of a 30,000 feet view of what's happening in this case. I mean, it's a new disease. We don't know much, and there's rarely, when we started off doing this, there was hardly any information on arrhythmias, and that we have more now, but not enough. And I think I hope that this sort of creates sort of a baseline on which people can build on. And we are not claiming that this is the end all and be all, but I think this gives us a sort of a canvas, or like a overview of what's going on in terms of types of arrhythmias, as well as treatment strategies. Secondly, I think just to add to what Faisal said, I think the ability to get this kind of a global participation from the arrhythmia professionals, I think that actually tells you how the power of communication, how the capability of HRS to engage the global EP community. And lastly, I mean, it also shows that the EP world is digital, and it's very, very flat in that regard. And I think, obviously, as Faisal mentioned, we learned a lot of things about how to create such things, surveys and similar type of things to gain impactful data. And lastly, I hope that this particular information here will spur future studies. Looking at, we need to do we need a lot of information. We don't know what happens in how is females differ from males in terms of arrhythmic manifestation, what are the racial differences between those things, and how, again, resource issues, and how is there any particular predisposition to some people developing these things versus the other. So I hope that those kind of more targeted studies and larger studies with longer term follow-up. And lastly, I think I would really be interested in what happens to these patients long term. And one last thing is, without this also, I mentioned teamwork. This is truly a teamwork between the HRS staff. I really want to thank Christina, Chris Murphy, and Ashley Bannock, who really works so hard to get this survey put together and to facilitate and shepherd it along the way. And without their help, it would not have been possible. Along with our communications committee team, myself and Faisal, along with all our other members who are not here, but they are equally important, and the Global Ambassador Committee led by DJ, and last but not the least, your support and guidance, Andrea. And I think that has been incredibly important to get us to get things moving and achieve this success, and get this data in good time, and get to publication so that we can share this information with the larger electrophysiology and cardiovascular community.
Well, that's great. No, thank you. And thank you also for bringing up all the hard and endless work of the staff of HRS and making all this happen, and for everyone. I think, the global engagement, the global reach of the communications committee, of all of your work, and also the ambassadors group, the opportunity for the scientific community to rapidly share information. This is really, one of our initiatives in HRS is digital health, and this is even further jumpstart for digital health. So enhancing collaboration with our partner society. So I just want to thank everyone for your hard work on this. Thank you all who are viewing this session, and thank you all for your participation. I really appreciate it. Thank you.
Thank you.
Thank you.
Thank you.